For the next session, I invite the chairpersons, Dr. Narayana Swamy, retired professor and head of Department of Cardiology at Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore, Dr. Manjunath Hande, professor in KMC, Mangalore, Dr. Lakshmi Narayana Samaga, professor at Shema, to kindly take your seats. I invite Dr. Martin Green onto the dais to speak on Brugada syndrome, malignant early repolarization syndrome, what is it and how to recognize it. I request the chairpersons to introduce Dr. Martin Green.
I request Martin Stephen Green to start his lecture.
This time we'll talk about Brugada syndrome and malignant early repolarization syndrome. I find these very confusing. I don't really understand the early repolarization syndromes, and I'm not really sure I understand the arrhythmogenesis. And I think it's critical that we understand that early repolarization on the ECG is common, but this syndrome is relatively rare. So we'll talk a little bit about how to recognize it and what are some of the features. So what is Brugada syndrome and what is malignant early repolarization? If you look at the primary electrical diseases, the diseases we call ion channelopathies, they include long QT, which you've heard about. They include catecholaminergic polymorphic VT, which you haven't. But they also include short QT syndrome, but they also include these other channelopathies, Brugada syndrome and what I call the J-wave syndromes, or malignant early repolarization. When we go back to 1992, so there were reports of what we now call Brugada syndrome prior to 1992, but it was the Brugada brothers who put it together, and the first publication was just 8 patients. Interestingly, even at that time, it was male predominance, and Brugada syndrome typically is much more common in males, often occurs with sudden death during sleep. So their first publication was what they called right bundle branch block and persistent ST elevation associated with sudden cardiac death. We now would say that it's probably not truly right bundle branch block, but that's what the ECG looks like. And this is the typical ECG in Brugada syndrome, this coved, elevated, downsloping ST segment, most importantly seen in leads V1 and V2. That's the very typical ECG associated with Brugada syndrome. When I go back to publications that showed causes of unexpected sudden cardiac death, and they look at the causes, we see that still cardiomyopathies are more common, CPVT, this one was from Europe, long QT, and Brugada syndrome was relatively unusual in a relatively unusual event. It was an unusual cause of an unusual event. And even then, to come up with this, they were already doing pharmacologic challenge to bring out Brugada syndrome, and that publication was 2005. What's notable in its absence is there is no malignant early repolarization syndrome, no what we'll call the J-wave syndromes noted in this 2005 publication. Now, here's another one, family diagnosis in family members with sudden cardiac death, and again, Brugada syndrome, 9%. This is 2008. The other ones, long QT especially, overwhelming it, and some of the cardiomyopathies overwhelming Brugada syndrome. Again, malignant early repolarization not there, 2008. Just shows you how recent the description of this syndrome was. This is our own. This is the Canadian experience, which was published in the CASPER trial. So this is Canadian, and Andrew Cron was the first author. But this was now published in 2009. Again, Brugada is relatively uncommon, but now we start to see diagnoses of early repolarization syndrome. I am sure they were there in the previous families. They were just either missed or misdiagnosed as something else because we didn't really know what to look for. We called them idiopathic VF or whatever. But by 2009, we'd already heard about it, and in the Canadian experience, we now have early repolarization as one of the causes of these ion channelopathies. So let's talk about Brugada for a second. We showed the ECG showing ST elevation in V1, and I'll show you some examples of the different type of ST elevation in V1 and V2. But the most important one, which we call the type 1, is that coved one that I showed you. But saddleback is also seen, but is probably not as malignant. So here's the typical coved ST segment, type 1, and here's the saddleback, and here's the saddleback without ST elevation, the so-called type 3 Brugada. Interestingly, these are all from the same month in the same patient. So all of a sudden, we've got a problem. We've got a big problem, because here we see a grossly abnormal ECG with, in a person who's had syncope or resuscitated sudden cardiac arrest. It's easy to make the diagnosis. We see the same person at this point, and we would never make it. Just to show you that if you have symptomatic Brugada syndrome and you don't end up with a defibrillator, the mortality is quite significant. This is over 5 years, and you see sudden death and syncope, recurrent syncope, being very high in the symptomatic population. Okay, so let's talk for just a minute about what Brugada syndrome is. We've already seen the different action potentials, but we see this in the epicardium, we see this spike and dome, whereas we see much less of it in the endocardium. And this gives the opportunity for a gradient of ventricular activation, a gradient of repolarization between the endocardium and the epicardium. And this can be associated with this ST elevation or this late R wave, which we call right bundle branch block in the coved ST segment. And this can give rise to phase 2 reentry. In other words, again, it's this dispersion of repolarization which gives rise to the arrhythmia. And so that's what Brugada syndrome is. There are many things that can trigger it. I'm not going to go into them, except to say that fever and drugs are the two we should be commenting on and we should be thinking about. And in particular, we actually use this to help make the diagnosis. So we actually use drugs to challenge this repolarization, something that's going to increase this gradient and bring out the coved ST segment in a person who doesn't necessarily have it. We can do that with procainamide, ajmaline, or flecainide. Some drugs, quinidine, for example, may actually normalize it. So in Canada, in the CASPER study, one of the reasons why we maybe had a little bit more Brugada was because we were looking specifically for Brugada syndrome in these people. These were people who had no diagnosis. And here's a procainamide challenge on one of these patients that actually shows marked ST segment elevation in V2, unmasked by procainamide in a patient who was diagnosed ultimately as having Brugada syndrome. At baseline, no ST segment elevation in V1 and only the saddleback appearance in V2. And this can be corrected with isoproterenol. So here's another patient that Dr. Ancelovich published, a type 2, that is a saddleback with ST elevation, given intravenous procainamide, which becomes a typical type 1, and given quinidine and normalizes. The other thing we can do to bring out the coved ST segment is to use non-standard ECG lead placements. So you heard today about where you should put the leads. For Brugada syndrome, sometimes to bring it out, and it's probably because one of the channels, ITO, is more expressed in right ventricular outflow myocardium, and so you have to go higher. So if you put the electrodes, instead of in the usual spots, 1 or 2 interspaces higher, that is the V1 and V2 electrodes, you can often bring out the abnormality, and I'll show you that in a second, because it's important to realize that it can be completely intermittent. This is the same patient. This is one of our patients. Totally normal ECG, abnormal ECG, And if you see the patient and suspect it, and they have that at this point in time, you have to keep looking. So here is the 48-year-old man with syncope and a family history of sudden death. Here's his ECG. You see saddleback in V2. V1 is completely normal. V3 is completely normal. Hard to make a diagnosis based on that. We put the same time, this is like 2 minutes later, put the electrodes one interspace higher for V1 and V2, and now look at V2. Typical coved appearance of the type 1 Brugada ECG. So you have to learn to unmask the Brugada syndrome if you suspect it. It's not always obvious. You have to either use a drug challenge or move your ECG leads an interspace or 2 interspaces higher. So that's Brugada syndrome. Let's talk for a second about malignant early repolarization. If you think I didn't understand Brugada syndrome, now you've really got a problem, because I truly don't understand this one. This was first described in 2009. We've all seen ECGs that show what we call early repolarization, ST segment elevation in a complete normal. The arrhythmic mechanisms are poorly understood here. But early repolarization is a common ECG finding, especially in the young or in the athlete. I wonder, is this one of the things we used to call idiopathic VF before we knew about this? So here is the prevalence of early repolarization, that is ST segment elevation, in a group of patients. This was the Israeli group from Arnon Adler, Sami Viskin's group. And they looked back at their idiopathic VF patients, and about 70% of them had horizontal ST segment, this early repolarization in ST segment. I'll show you that in a second. Match controls, it's much less frequent, and in young athletes, it's present in all of these, but it's much less frequent. And when you did have J-point elevation, you had a ascending rather than a horizontal or descending ST segment that went with it. So this is the first report of this malignant early repolarization. And what you see, here's a person with a totally, looks like a normal ECG. And the first thing that happens is they develop ST segment elevation. Is this ischemia? Not sure. Some PVCs. And then we see this J-point elevation with this descending limb here associated with this ST elevation, and ultimately ventricular fibrillation. Here's an ECG from one of their original patients. Look at this. So this is not the typical type of early repolarization that we would see, for instance, in the athlete. This is the descending and horizontal ST segment. Totally normalizes with isoproterenol. So let's look at this again. Here I've blown it up for you. Look at this. This is a very abnormal type of early repolarization. It's not the thing we see in young athletes. It's not the thing we see in normals. This type of ST elevation, this J-point elevation, has a descending limb and a flat or descending ST segment, as opposed to, there's what we're talking about. Oh, this is one of the patients from the Casper study. So this is, again, one of the Canadian patients in the Casper study. And I want to show you this ST elevation again. And then look, this is all within a few seconds. Look what happens to this ST segment. We see this descending, very, very abnormal J complex, followed by ventricular fibrillation. Look here when it terminates. 1 beat later, this is completely normal. It is gone. This is a transient phenomenon. So if you think you're going to find a person who's had a previous syncopal episode in this, just by looking at the ECG, you might be wrong. It's not that simple. Here is, I've taken a piece out of this from here, and then only a few seconds later, look, compare this to this. This is seconds. This is not minutes or hours. This is seconds later. This is a continuous strip. Look how transient this phenomenon is. Now, when the Israeli group looked at the prevalence of the type of J-point elevation, they put together all the literature, And the blue bars are the rapidly ascending ST segment, which you see with the athlete. And the red bars are the people who have this descending or horizontal ST segment associated with it. And here's the idiopathic VF sudden cardiac death group, or even the myocardial infarction with VF. And they have this very abnormal segment. Whereas in the young athlete and in the normal and the healthy, it's generally this ascending ST segment elevation. So lastly, I'm going to present you one of our patients. You can see the date is just July 2013. So this is a patient who'd had syncope during exercise. And here's a loop monitor. And you can see this little ST elevation. You see ventricular tachycardia at the point they have their syncope. And then you see a completely normal QRS. This occurs over minutes. So I'm going to show you the complete tracing now over a few minutes. He's exercising. It's 6:33 in the morning. He goes out for his run. And his QRS, as you see, and his J point, totally normal. Over a few beats, he develops ST segment elevation. But what happens next is his ST elevation goes away, but look how this looks like QRS widening now. You see, this here is really this J point elevation already. This is seconds later. As he continues to exercise, the ST segment is down, but this J point elevation, which looks like a very wide QRS, comes, and then he ends up having an episode of ventricular tachycardia. I showed you this part already. And then he recovers, and you again see this J point elevation, and a few seconds later, it's completely, totally normal. So you can see the difficulty in trying to diagnose this. Here's his ECG after he came in. Once we saw that loop monitor, we called him in. He said, "Oh, that's great because I just had one of my episodes." So here we go, and look at his ECG. Again, he's got this little bit of descending, this J point elevation associated with a descending limb and a flat ST segment, the one that we thought was malignant. We don't know, this doesn't occur frequently in the normal population, but we don't know how frequently it really does occur. Of course, because he had ST elevation, there it is again. You can see that there. Because he had ST elevation with exercise, of course he had a cath. His echo was normal, showed normal LV function. His cath showed a 70% LAD lesion. The interventional cardiologist described it as, well, maybe it looked a little fuzzy. So he stented the LAD. I don't blame him. So here's my question to you. Is that enough? Have we done this guy the right treatment? Does he need an ICD? I'd ask your opinion on it. We gave him an ICD. I just want you to know that. But I have no idea whether it's the right thing to do. I find it hard to imagine that what we just saw there was all ischemia. I find it hard to imagine. That ECG does not look like just ischemia. I think there's something else going on. So I think that the mechanism in some of these people is ischemia that triggers this very abnormal response, which is arrhythmogenic. And I think some of our people with MI who die with VF probably are related to this, that ischemia triggers it. So my last slide, this is a patient, I'm reading ECGs now. This comes across my desk. I'm reading ECGs. So I read this ECG and I say, whoa. So I go back and I try to phone the doctor and pull out the chart. This man is well. He's 2 months post-cabbage. What do I tell the doctor? Look at this ECG. I now would read this ECG as being abnormal. I think 5 years ago I would have totally ignored that. I have no idea what I would have said. But now I find it difficult to call this ECG, this J point, normal. I don't know what to do. I don't know what to tell the doctor. I'm certainly not taking this asymptomatic guy and giving him an implantable defibrillator. But it's not impossible that one day we will have good enough ECG markers that we'll be doing that. So I think this is a difficult subject. I think it tells you how much the field has evolved and how much we are learning. This is a relatively new syndrome. We don't understand all the mechanisms. I think there's a lot yet to be learned here. So stand by. I think we're going to learn a lot. I think people will be looking for this over the next few years. I don't think we have all the answers. Thanks very much.
Thank you, Professor Green. First of all, I must congratulate you for such a wonderful lecture within your allotted time. Though you told these are rare conditions, but the clinical situations, these conditions must be suspected are quite common. That the presence syncopal attacks, sudden cardiac deaths in family are quite common. So this is a very appropriate topic. I think our audience may have a lot of questions. You may.
Let me just make a comment about rare, because I think the early repolarization syndrome we would all call rare, and I think it probably is mixed up a lot with ischemic VF and with idiopathic VF, and I think it may not be as rare as we think, but I think we're just in an early phase.
I've got two questions. One is this Brugada syndrome. Will it be included in this J-wave syndrome, or it will be separate from J-wave syndrome? And second thing is what we call as benign early repolarization. Is it benign, or it has got also slight more repercussions?
So the first part of the question was Brugada syndrome. I think I'm a lumper rather than a splitter. I think if you go to Southeast Asia or even South Asia here, if we talk about Thailand or the Philippines, where young men die in their sleep, that's a different syndrome than this malignant early repolarization, where it often is occurring with exercise. It's typically, they're more common both in males, but I'm not sure they're the same. So I think right now we should split. I think we don't understand all the mechanisms. I think it's probably appropriate to split them until we find out more about the mechanisms, understand it. As a clinical syndrome, they're different. The mechanism of arrhythmia might have a lot of similarities, but I don't think we're there yet. The second part of the question is, should we be worried